Welcome, everyone, and thank you for joining us. I'm Amanda McGill-Johnson, Executive Director of Nebraska Cures. We are a nonprofit that supports, promotes, and advocates for scientific research for the betterment of our health and our economy. And today, I'm excited to be hosting a seminar taking a deep dive into pregnancy-associated hypertension and how we can use current research to mitigate it. We have three guests who are with us who will do brief presentations, and we'll pause for questions in between each of those. So that will be the time you can drop a question in the chat and we'll address it at that time, or you could unmute yourself and ask yourself as well. Our panelists today are Dr. Ann Anderson-Berry, the Executive Director of the Child Health Research Institute, and her colleague, Dr. Corrine Hanson, Professor in Medical or Director of Medical Nutrition Education with the College of Allied Health Professionals. We also have Lashelle Freeman, who is a mother whose hypertension impacted her pregnancy. So we're very grateful for all of them being here today with us. And with that, I'll turn things over to Dr. Anderson-Berry to talk a little bit more about this issue and why we're here.
Thanks so much, Amanda, for hosting this. We think that it is incredibly important for the general community to understand a little bit more about pregnancy-associated hypertensive disorders and the impact they have on our community, our moms and babies, and the ripple effect that that has on families and an assorted extended group of people. So it's a pleasure to be here. I am a neonatologist by training, and so I take care of premature and ill infants who need a little bit or a lot of extra help around the time of their delivery. I work closely with maternal fetal medicine specialists and obstetricians who are key at diagnosing and treating hypertensive disorders of pregnancy. And obviously, I work very closely with our families who are impacted by this disease. And that's one of the best and also hardest parts of my job, because we really have a lot of work to do to support, in these instances, a baby who is often critically ill because of premature delivery and a stressful intrauterine environment, as well as a mom who can be incredibly, incredibly ill. People may not understand how profound hypertensive disorders of pregnancy can impact a mother's health. So I'm going to I have a few slides for pictures just to kind of raise a point around exactly how prevalent hypertensive disorders of pregnancy are and why we are thinking about them, unfortunately, more and more in 2023 than we were even historically. So this slide is slightly dated, but it demonstrates the trends in hypertensive disorders in pregnancy and chronic hypertension really over the course of 20 years. So it goes through 2014. So it's about 10 years old, but you can see an increasing rate of hypertensive disorders of pregnancy. And these are per 10,000 deliveries. And then we also have moms who have chronic hypertension, and those rates are rising as well. And so if you look at moms then who are delivering in 2014 with either chronic hypertension or a hypertensive disorder of pregnancy, then 1 out of every 10 pregnancies in 2014 was impacted by hypertension. I will tell you that in the last 10 years, we have seen a continued steady rise in hypertensive disorders of pregnancy diagnoses and chronic hypertension disorders. And so it is likely that this is, much closer to, say, 1.5 out of every 10 pregnancies, and will continue to increase. So the hypertensive disorders of pregnancy include this chronic hypertension. And so that's a mom who has elevated blood pressure before she gets pregnant. Then we have gestational hypertension. So that is a mom whose blood pressure increases throughout pregnancy, but it's something that can be managed and monitored, maybe treated with some oral medications. Then getting a little bit more severe is pre-eclampsia. And pre-eclampsia is when your body and your placenta start to change how they are functioning because of your hypertension. And so you might not be filtering your blood to make appropriate urine. You might start to have a buildup of fluid that impacts your vision, your headaches, your balance. You might have poor filtration of blood and perfusion of your liver. So you start to not make appropriate blood components like the platelets that help you clot. You might start to dump a lot of protein in your urine because of injury to your kidney. And then worst, after preeclampsia, if preeclampsia is refractory to treatment, is eclampsia. And that is associated with high mortality or death, and also significant morbidities or complications due to that disorder. And eclampsia is when you have all of those body changes and you actually have a seizure, and it can be incredibly traumatic. And as I said, deadly for mom if preeclampsia continues on in severity and transitions to eclampsia. So the worldwide impact of hypertensive disorders of pregnancy in a year is 70,000 maternal deaths and 500,000 fetal deaths, usually from poor blood flow to the placenta, having to deliver premature infants, incredibly premature, and having them not survive that hospitalization. So I hope you can understand why, as healthcare professionals, we have so much attention focused on diagnosing and treating hypertensive disorders of pregnancy, but why we're also excited to be here today. And Dr. Hanson and I focus so much of our careers on this is we are interested in mechanisms of hypertensive disorders of pregnancy. Understanding those will help us to implicate possible preventative measures. And for individuals who are impacted by this disease, like Lashelle and her family, I think they would probably agree that prevention would be their number one priority to impact their child in a different way, to have that family not go through the trauma that Lashelle is going to talk to you about in her experience would be my goal as a physician and as a researcher. So just one more slide, and then we'll probably turn it over to Lashelle so you can hear her talk. But when we diagnose chronic hypertension, which is elevated blood pressure, this is diagnosed before pregnancy or before the 20th week of pregnancy. And obstetricians, internal medicine specialists, family practice docs, midwives will try medications to try to help lower that blood pressure. Preeclampsia is increased blood pressure after 20 weeks gestation, and then those systemic changes that I was talking about. So protein in the urine, headaches, swelling, things like that. And then gestational hypertension is increase in blood pressure after 20 weeks, but you haven't yet developed any features of preeclampsia. And then, as I mentioned, eclampsia is the most severe consequence of preeclampsia. So I'm going to stop my sharing now, and I think we would be happy to pause for any questions around this section of the discussion, and then we'll turn it over to our wonderful Freeman family for a little bit of personal experience and having each of you understand the impact on the family. So happy to have you unmute for any questions, or feel free to type them in the chat as well. This is a very informal conversation.
Sure. Thank you. Hi, this is Yogita. I have a question. I'm 22 weeks pregnant at the moment. In my 12th week scan, I was diagnosed with high risk for developing preeclampsia, and I've been taking aspirin for that. And in my 20th week scan, which was last week, I was told that I have moved into low risk assessment for developing preeclampsia. I'm not sure how to interpret that, and what does that mean?
Well, I will start by saying that I am a neonatologist, so I take care of babies. I know a lot about hypertensive disorders of pregnancy because I take care of the families. But medically, I really take care of the babies. And from a research standpoint, we're really looking at many non-clinical things. So I don't want to give you any medical advice, but I would say that's wonderful news to be taken down a risk category. And I will say also that aspirin is one of the only treatments that we can consistently recommend for moms who are at risk for developing hypertensive disorders of pregnancy. And so without knowing anything about your case and not wanting to give you any specific medical advice, it would appear from what you're describing that you were a good responder to that aspirin therapy. And so that is, I would say, something that you should be pleased with, but certainly monitoring your blood pressure and really thinking about, asking your provider, what are next steps and what do I need to be looking out for in case you were to develop pre-eclampsia would be very important. And it's something that every mom should be aware of is, if I am having swelling, if I am having headaches, if my urine gets dark, those are the times that you need to call your provider and talk through your symptoms so that you can get appropriate care.
Got it. Thank you. And would you be able to advise how frequently the blood pressure needs to be monitored?
I think that would be specific based on the clinical case. And so a really good question for your provider.
Sure.
Dr. Anderson-Berry, this may be coming up on some of your other slides, but do you want to say anything at this point about what some of the causes for this increase might be? The causes for the number of increases in cases, I guess?
Yeah, Dr. Hanson and I will review that a little bit, but there's a general group of suspicions. The first is that we don't have the best diet in the United States. And so we have a high sodium diet, a diet that's very high in processed foods, a diet that's very high in red meats. And all of those things can contribute to the development of hypertension in any population. In addition, it is unfortunate but important to understand that women of color are at much higher risk for developing hypertensive disorders of pregnancy than other races and ethnicities. And one case that I always like to call out, because I think when I start to talk about, diet and exercise, it can feel like if you got hypertensive disorders of pregnancy, I'm pointing a finger at you. And that is absolutely not the case. Serena Williams, who's heard of her? Who hasn't heard of her? She almost died in childbirth from hypertensive disorders of pregnancy. There is not a richer woman well, there's probably a richer woman in the world, but she's in the top 0.0001% of socially endowed. She's got access to the best diets, access to the best training. Is there a more physically fit person in the world than her? Probably not. And yet she almost died in pregnancy. And so we understand that in the US, women of color are discriminated against, and they endure incredible amounts of stress from childhood through delivery and beyond. And so part of the research that we're doing in our group is trying to understand how social stressors from structural racism impact hypertensive disorders of pregnancy as well. And I didn't ask Lashelle to comment on that. I think that's a really personal experience. We were going to focus more on her clinical presentation and her NICU experience, but if she wants to focus on this, that would be fine too. But it is an entirely different experience walking through the world as I do as a white woman versus my colleagues and friends who are Black women. And so I think we have to acknowledge that and say that in some ways we're fighting a really strong uphill battle in trying to care for women who have chronic stress that's not of their own doing. So that's a great question.
Great. Well, we will switch over then to visiting with Lashelle. Welcome and thank you for joining us to share your story. It was great seeing your little guy there in the video.
Oh,
for a
yeah,
few
he's my
moments.
little angry bean. So he has a lot of facial expressions. It's all in the eyebrows. Yeah, so
Yeah, I can ask you a few questions. I
yeah,
know-
definitely, yeah. I'm just really nervous, I guess. But to answer what Dr. Anderson, is that okay, Dr. Barry Anderson, was talking about like the whole like race thing. I've experienced that a little bit. Like at first people think, you know, like, oh, she's gonna be mean or she's gonna treat me different, you know, so they start out kind of like treating you like just not really conversating with you. And I did have a nurse that was kind of like that at first, but then when she like heard me talk and how I was as a person, she was like, oh, awesome. Like she started to come around more. And then that's just how it went from there. So it kind of starts out shaky, I guess, because they don't know if I'm going to be like that angry Black person or that angry Black mom, you know, or if I'm going to be rude or like snap at them for things. And, you know, just to see her reaction, you know, I was like, yeah, I'm not a mean person. Like, you know, and yeah, it was just great, you know, all around, but her mood kind of changed and how she like, you know, talked to me and stuff like that. So that was one kind of experience, I guess you could say. So yeah, whatever questions you have for me. Sorry, yeah.
Thank you for sharing that and addressing
of course.
what it had brought up. The first question is, well, first off, I know this was your second child that landed you in the NICU and
Yeah.
this experience. What going into this pregnancy were you expecting pregnancy to be like, I guess?
Completely different from my first one. So I thought this one was going to go smoother because, you know, one, I've been working on my health, like eating healthier, just trying to keep stress out of my life. I've been working on that more. So I thought this was going to go smooth, and it did go really smooth. Like this was the pregnancy where I wasn't a diabetic, gestational diabetic. I didn't have to poke my finger or write down my blood sugars and stuff. So that was a big one because I passed the glucose test and I was like, yay. So everything was going really good, you know, and then like I mentioned to you when we were talking earlier, just definitely the stress of, you know, having somebody in your life that causes a lot of stress can really turn things around big time. So, and that's kind of what really affected me big time was all that stress and negativity. It hit really hard and things kind of went downhill from then. So yeah, that's kind of where, sorry.
Where things
kind of where,
yeah. That's okay.
yeah, it took a big turn. Yeah, it really took a big turn. So.
And I know Dr. Anderson Barry was talking about just race and some of that toxic stress. But that toxic stress can also come from a personal relationship or just like circumstances that are maybe layered within there, and that's what you kind of was a trigger event for you.
Yes, the big one,
So you went in based on, you know, that trigger event, those relationships. What happened from there?
Well, after that whole stressful night, the 29th, things changed. So we went in and my blood sugar was really, my blood pressure was really up, really high. And they were trying to get it to come down and it wasn't coming down. And the person who was there with me, well, she showed up and she was stressing me out even more because she popped up out of nowhere. This person did. So that didn't help at all. So they're trying to get my stuff to come down and she's still there, you know, causing issues. So, you know, they were like, we're going to take baby. And so I was like, oh no, now, you know, because the plan was to wait, you know, a little longer.
How many weeks were you at? Excuse my interruption.
That was 32. Let's see, 32 weeks. Yeah. So it was a lot. it was really sad. So there were a lot of feelings going around at that time, and they were like really in a rush to get me to the surgery to get the baby out and everything. And it went by so fast. And like all I could think about was like, oh my gosh, am I gonna be okay? Is baby gonna be okay? It was really sad. So when they took him out, I only got to take my finger to his finger, you know, got to hold his little finger, but he was in like a box thing. And it was really sad because they took him after that. So I didn't get to see him. So that was like my only contact I had with him, was just that little finger, you know. And so that really broke my heart because I was like, wait, you know, here I am, like, you know, feeling like everything's going good and I'm okay, you know. And at the moment, I was okay. You know, they were putting everything back together and everything. And I remember really wanting pineapple, which is totally random. So, and and I always tell everyone, I'm like, pineapple saved my life, because I ended up throwing that up, you know, then the hemorrhage and everything. So event after event, after the pineapple, just event after event. So, but yeah, it was heartbreaking just to only touch his little finger and to see him in that little tube. And you know, you can't really move your whole body to look at him because you're laying there while they're trying to put stuff back. So they were just wheeling him by me, and I was just like, okay, you know. So my other half actually got to, you know, be there with them, you know, while they were explaining things, how things worked. And he got like a little photo shoot in. And so I'm like, well, at least you got like a whole bunch of photos, you know. So I didn't get that, you know. So
What was the NICU experience like then?
The NICU experience, it was incredible. I really liked it. It was sad, yes, you know, but everything, the nurses, the care, like everything was great. I felt like I was actually there, and I also felt safe that my baby was there. You know, there were times where I would freak out or panic because I'm like, oh my gosh, you know, he's just laying in that crib, you know, and they're walking around doing stuff, but you know, there's a monitor, you know, and stuff. And I would, you know, really worry. I'm like, oh, like no one's in there holding him all the time, you know, but they made sure to give him all the care and love, you know. I got pictures of him through the Angel app that they had. So that was really nice. That's a great app. So if your baby's in the NICU, like always request that app or to have them communicate with you. So it's really awesome. And then is it okay if I show them what some of the nurses did? Yeah. Okay, so the nurses really try to make their rooms look really homey like, and so they do little arts and crafts with the kids all the time, and like it's really adorable. It's like you know, one big happy family there, and I really like it. So I was really grateful. I had a really great team, so I'm really grateful that everyone saved my life and did all they could do to get me to go see my kid. So yeah. Yeah,
we did have someone answer, and I'm not sure because everything happened so quickly. I'm not
sorry if that was really long.
No. I'm saying like in the moment when this was all going down in November. Somebody just asked if they took you straight to surgery or if there were other options that were discussed. No,
they literally were like at that moment they were trying to give me a whole bunch of the blood pressure pills, if that's what it's called. They were like these little gel looking pills that I had to take, and I took quite a few of them. I remember that they were trying to get my blood pressure down, but it still didn't go down. And at that moment, the nurse came in with the gown and everything. She's like, we're taking you back, let's go. And so it was, you know, there was no yes, no, like wait, you know, they were like, let's go. So, and that's why I meant it happened really fast. They got my other half dressed in his gown and stuff and helped him out. And yeah, it was a quick process. They had the anesthesiologist, is that what I want to say? The guy that comes back and puts the finger back, is that the person? Sorry. He came and he was like, okay, we're gonna do this, you know, and that happened quick too. So they did the whole thing and numbed my body real fast, and yeah.
There's another question, you know, someone asking for a follow-up question on your experience about you mentioned hemorrhaging, and was that linked to the preeclampsia or?
So basically, what happened was after I ate a whole bunch of pineapple, it didn't settle well. I mean, I literally ate right after the surgery, so I don't think that was such a smart idea to do. But I was really hungry, and I really wanted pineapple, so I ate pineapple while I was in the recovery part of the surgery, like that room they put you in. And after I finished eating, I felt funny, and I told one of the nurses that. So she had already had like a throw up bag ready for me. Then my room got ready and they were like, hey, we're going to take you back to the room. And I'm like, okay, awesome. I'm ready to go. So they wheeled me back to where my room would be at for while I was staying there at the hospital. And then next thing you know, I was like, hey, I don't feel good. And all I remember at that point, and because everything else is a blur, I just remember throwing up a lot. And then I remember my other half yelling, and then a nurse freaking out. And then I remember looking up at him and him telling me it's going to be okay. And then everything went black after that. I don't remember after that. All I remember, and then I do remember voices saying, lift up the blanket for blood. And like, I guess everything was like, there's like a lot of blood everywhere. So I don't remember that part. But I do know that there's some parts that Dr. Lessman and my other half won't tell me. They just don't want to talk about it much, but it was pretty traumatizing for them. I can only imagine what they saw and everything, but it was pretty traumatizing, I guess, for them. And then me, I don't really remember much. I did kind of pop in and out, and I did remember another doctor coming and putting like a ultrasound on my stomach or something to look for something like the blood clots, I guess. And yeah, so that doctor, she saved my life big time. I do remember her. I just can't think of her name, but she literally was like, let's get this done. And she really saved my life. So I don't know the whole story to that part. So yeah.
Thank you for sharing all
Yeah,
this.
sorry.
Just talking about your spouse too, that they have this experience in parallel that's a little bit different and unique too.
Yeah.
So how's baby doing now, and what advice might you have for other moms, or
baby's doing great. Sorry to take your time. Baby's doing great. He's getting bigger. We just have a few complications with his breathing stuff. And that's just because I feel like maybe he wasn't fully ready yet, and they had to give me that shot to jumpstart his lungs. So just a few complications, but nothing too like crazy. We're going to a feeding specialist now. He is drinking 6 ounces, and he did gain weight because he was only 4 pounds when we started. So he is 12 pounds now. So, and he's a chatterbox. So it's pretty funny. But yeah, and then my advice for other moms is definitely, if you're going through a stressful situation while pregnant, just tell yourself, no, it's not worth it right now. Make sure you're reaching out to your resources and getting help with a toxic or stressful situation, because it's very important. You don't need to go through that while you're pregnant, because that can cause a lot of issues with your pregnancy. So yeah, that's pretty much it. Make sure you reach out. Yeah, sorry.
Oh, nope, that's great, Lashelle. Thank you so much for your willingness to be so open and to share your experience with us.
Yeah. Thank you. Sorry to take up your time.
No, you did it.
Don't apologize.
Yeah, everyone's super great.
I have 2 more questions for you, Lashelle, that I think are important. And I see Ellen Trumbull has the same question in the chat.
Yeah.
What resources did you have after this experience that were good for you? And what resources didn't you have that, as you look back, you think, oh, it would have been helpful if I had somebody to do X or tell me about Y? Anything that you like we missed?
Pretty much all of the resources were great. I literally, the NICU, like the support group they do there, there's a beautiful lady that does like little crafting activities with the NICU moms. And that's how I met a few of the moms and became really good close friends with them. That's a great way to get some support going for yourself. I love the resources for your guys' feeding specialist that you guys have there. I don't know if that's the right name for her, but she's incredible.
She came and looked at my bottles to check them out to make sure they were going to be okay for baby. I really like the breastfeeding specialist that you guys have, the breastfeeding team. And there's a lady named Denise who's in charge of the car seat stuff, or she's just over the whole I want to say like safety stuff back there in the NICU. She does a lot. She's incredible. So she helped me with the car seat stuff, explained a lot to me about the car seat because that was something he was struggling with coming home, was passing that test because of his O2 levels. So she was great. Everyone was incredible. Even the care nurses that would take care of him, that they gave me great resources on like just like ways to feed him, how to bathe him correctly. They did printouts for me. There's videos that they have you watch for certain things. Anything you can think of, those nurses and just anyone back there, they'll give you whatever you need pretty much. They were great. Even you were great too, Dr. Anderson. Thank you for always being there. So thanks for popping in all the time. So you're incredible. So you're a very powerful and amazing woman. So thank you.
Well, you are kind. Can I ask you one more question? And then Dr. Hanson and I will talk a little bit about the research that we're trying to do so that people don't have to go through what you did. For many women, hypertensive disorders of pregnancy don't end at delivery, and they need to continue their medical care to treat their hypertension for an extended period of time. Would you be willing to share what your course has been like for your health?
Yes, right now it's going really good. Definitely lost a lot of weight. So I was at 257 November 29th. Now I'm 198. Definitely diet, eating healthy. The medicine I'm on, they stopped metformin for right now until I go back to do blood work to check to see if I still need to be on that. And then recently I'm getting some help with the postpartum part of things. So I'm taking steps with talking with the therapist for that. And then Dr. Lessman, who is my OB, she's been really great with appointments wise, making sure that everything's okay. I'm healing okay down there. And just making sure that I'm watching for like any like off signs of things. So like definitely since I have a irregular period, she wants to make sure that we're keeping track of that to, you know, watch if there's something else going on. So yeah, just taking steps to recovering is going great right now. So
that's really good to hear. I think there's a myth that once the baby is born in hypertensive disorders of pregnancy, that the problems are solved. And that's something else that we're trying to kind of stamp out that myth. Moms need health care for an extended period of time.
Yeah, they do. Yeah, definitely. I would definitely say so. I'm still having, like, I still have a little bit of numbness down below. So, and I still don't kind of feel all the same, you know, 100% right now. So I think I'm like 50%. So yeah, definitely with a lot of support. I would definitely say the therapy part of it is something a lot of the moms need. And you know, therapy is really hard for I'm not speaking for everyone in general of my race, but my race, like a lot of people don't believe in the therapy part of things. So it's hard to, you know, get the help, I guess. So I would definitely say that's really important. If anything, we need to extend that longer so people can talk about what's going on and their trauma. So
everybody who has a NICU delivery should get therapy.
Yes.
It is a traumatic experience.
Yeah.
And that doesn't add on hemorrhaging and almost dying, right? Like what you and your family have been through is a profound experience. And that's why this is so brave of you to come and share your story amongst all of these people who are here just to learn from you. And so we couldn't be more thankful for your openness, because if we don't talk about what this is like for families, then you know, it takes away the power that the personal story brings to moving research forward and improving clinical care. So I'm going to speak for all 24 people on here and say that you are our hero today.
Oh, you guys are the heroes. I wouldn't be here, if it wasn't for you guys. So thank you. I just really wish that I would have gotten that experience to be there with my baby, right after I had him. So that's,
Absolutely. It is,
thank you.
again, something that really needs to be acknowledged and addressed.
Yeah.
So
Sorry to take up your guys' time. Thank you.
no, this was the
you.
important part of the talk. Now
And I
it's
hope I answered stuff okay. So I know I can chat quite a bit. So so thank you.
yes. Yep, exactly. Joanna says, thank you for sharing your story.
Yeah.
Everyone is like I said, I'm going to know that everyone on this call is so much more appreciative of you than of anybody else or anything else they're going to hear.
You guys are awesome.
Now here's the part that hopefully won't get too dry and boring. Corey and I are gonna try to keep you all engaged as we talk through some of the research aspects of why, Lashelle's story is why we come to work every day, to make sure that she doesn't have to endure this again. And so, Corey, did you want to go through this slide? Or did you want me to? We didn't really practice who was going to talk about what, but
I guess that is full transparency, isn't Anne and I did not practice who was going to go through what, but we've also worked together for long enough now that we can probably read each other's minds, I think, between this. I'll go through this slide just quickly, Anne, and then you can go ahead and take over, and we can just however we feel like it flows the best. But I also want to second everything, Lashelle, and just thank you so much for your story. I guess that it's just a really hard act to follow. Now,
Yeah.
I'm with
Yeah.
Anne that I feel like, okay, well, we're going to try and talk about some other stuff now. When you talked about what really matters, it is so incredible to hear those stories, but it does, I think, for her and I both, motivate us even more to say, we just really have to do our work. There has to be something that we can do to help.
Yeah.
There's got to be something else that might help. And like the slide says here, our research is nutrition. And so that's what we focus on as a modifiable factor, something that we can target that early on, as soon as people are identified for being maybe at risk for preeclampsia, we could intervene and say, here are some modifiable things that we can try to manipulate early on. And it may not help everyone, but if it helps a little bit and it helps a few people, it's certainly worth doing. And we focus on omega-3 fatty acids quite a bit in our research. One thing as we're talking about nutrition that I think is just kind of important for everybody to think about how they think about nutrition, like reframe your thoughts a little bit about nutrition, because I think one of the things that happens is people go, oh yeah, nutrition. Okay, yeah, all right. Everybody knows nutrition is good for you, and that's kind of boring, and that's what have you got here that's new? Dazzle me, really make me buy this and really make me believe it. And so for a second, I think the way we want you to think about this is that nutrients can be every bit as powerful as drugs, and nutrients are pharmacologically active. The things that you eat don't just sit there and do nothing benignly. They go through all sorts of metabolism and processes and things like that. And the end products of these things are these metabolically active compounds that can have a great influence over what happens next in the pathway. And so what we focus on is omega-3 fatty acids. And the reason that we're really interested in those is because that metabolic process, once you go through it all, here you can see here on the little slide, we've all heard of omega-3s. We probably all know that one of the best sources of omega-3s is fish. You can get it in nuts and seeds and some leafy greens and things like that. That's the alpha-linolenic acid you see on here, ALA. The two unpronounceable words there in the blue boxes that are DHA and EPA are specific fatty acids. And what we know about these two fatty acids in particular is that they go through a metabolic process that results in compounds that we call specialized pro-resolving mediators, or SPMs. There's an example right here, a couple of them. There's resolvins, mericin, protectins, all these just different molecules that run around in your body and do really, really powerful things. And the point of these molecules is to resolve inflammation. And we think that's really important, because if you have inflammation that doesn't resolve, usually nothing good comes of that. Inflammation is really important. You have to be able to mount responses to things that happens to you. Your immune system has to be able to respond to an insult. You have to be able to fight it off. But when you've got some sort of process going on where you have an inflammatory process and you can't damp it down a little bit, then a lot of times these are the things that lead to, for example, progression of diseases, maybe progression along that continuum of pre-eclampsia that Anne was describing. So we are able to actually measure these compounds in the blood, and not very many people. It's a new field. It's called lipidomics, and it uses big mass spec machines and all sorts of really special things. And there's probably only 2 or 3 labs in the world that can actually measure these SPMs. And we are lucky enough to be connected with a wonderful collaborator who is very knowledgeable about biochemistry and can measure these compounds for us. And so this is what we're focusing on right now. And so Anne, go ahead and take it away, and you can go through a little bit of what we're doing.
Yeah. So we believe that preeclampsia is mediated by abnormal placentation, or development and implantation of the placenta into the lining of the uterus. And so I apologize for all of the jargon on this slide, but essentially the placental cells, or the trophoblast cells, go into the lining of the uterus, or the decidua and the myometrium, and they infiltrate to some arteries that are called the spiral arteries. And the spiral arteries are lined with cytotrophoblasts that will make the spiral arteries wide enough to get blood flow from the mom to the baby and back again. And so if you have a healthy pregnancy, you have to have a really great blood flow to get nutrients from mom to baby, oxygen from mom to baby, and then waste products from baby back to mom. And so that is the ideal state. In a preeclamptic state, we have a narrowing of those arteries. And so you can see in this cartoon here, as compared to the previous slide, where these spiral arteries are nice and wide and we're seeing great blood flow. In the preeclamptic state, those spiral arteries don't widen out. They stay really narrow, and you get decreased blood flow to the placenta. The trophoblasts don't invade in well enough, so you get a shallow trophoblast. And this leads to an even more pro-inflammatory maternal state, or systemic response. I think what we haven't talked about is that not all inflammation is bad. Pregnancy is a pro-inflammatory state that is necessary to grow a foreign being in your body. You have to balance inflammation. Your body has to tolerate some foreign cells, but so that the baby can grow and thrive, but it can't tolerate too much foreign stuff, because then you could get an infection from foreign microbes. And so in pregnancy, you have a very delicate balance of a pro and an anti-inflammatory state. And in preeclampsia, we believe that the inflammatory state is tipped too far in the pro-inflammatory state. And one way our lab measures that, and there are a lot of different inflammatory markers, but one way our lab measures that is with tumor necrosis factor alpha, or TNF alpha. And we find that in preeclampsia, that is increased. That leads to cellular dysfunction. Mitochondria are the powerhouse of every cell, and they don't function as well in a pro-inflammatory state like preeclampsia, where there's elevated TNF alpha. And so then your trophoblast cells don't work well, your placental function is altered, and then we have continued complications of pregnancy. You know, we didn't talk also, this is such a complicated disease with 2 patients. So moms get really sick, but babies can also get really sick. If you have a poor placenta, your infant's growth can be impacted. You can have poor oxygen delivery, poor nutrient delivery. And so we really have two patients that are impacted throughout the continuum of this disease. So with these tighter spiral arteries, we know that our placentas are actually stiffer in preeclampsia. So you can imagine a steak that is well done versus a steak that is rare. You can think of your placenta as a big piece of tissue. And what we would like is a nice flexible placenta that can quickly move blood back and forth and nutrients back and forth. If that placenta gets stiff, then it's very hard for the placenta to do what it is intended to do. And we can actually measure placental stiffness by ultrasound in pregnant moms. And we know that a healthy placenta has an 8 kilopascal measurement of stiffness. A woman with preeclampsia, her placenta would have a stiffness of 25 kilopascals. And for severe preeclampsia, really bad disease, that placenta can get up to as much as 55 kilopascals of stiffness. The stiffer your placenta, that's also associated with maternal death, neonatal or fetal death, preterm birth, and low birth weight. And so it's a very dangerous condition that tracks and associates very closely with preeclampsia. So we are performing a series of experiments in our lab to try to understand this better. And, Corrine and I are not the only individuals in our lab. We have 5 graduate students. Dr. Tierney is here from our lab. I see her in the audience. And we've already talked about Dr. Nordgren, who runs our microassays, our lipidomics. This is a huge group. So Corey and I are here today, but you should know that this takes, 20 plus individuals to get done what we are doing. And so I don't need you to understand the necessarily the science behind all of this, but the general gist of our research is that we take human placenta from moms who deliver at Nebraska Medicine who are willing to be in research. And if a mom has a hypertensive disorder of pregnancy, we can take a sample of her placenta after she delivers. So no harm to the baby or the mom. We can isolate those cells from that placenta. And then we can look at the RNA or the transcribed products of the genes that are active in that placenta. And what we have seen is that in moms with placentas with a hypertensive disorder of pregnancy, the transcribed genes are very different than those genes that are transcribed from a placenta cell that is not exposed to hypertension. So we know just from this top set of experiments that different genes are activated when there is hypertensive disorders of pregnancy. In the center line here, this goes back to those inflammation and that TNF alpha marker of inflammation. And so what we are seeing is that TNF alpha is increased in hypertensive disorders of pregnancy. So we took cells and we gave them some TNF alpha. And then we looked at those placenta cells and saw how their mitochondria were reacting. And we did see that TNF alpha increases did associate with poor cellular function, poor mitochondrial function. Then we also took placental cells in this bottom line here, and we grew them on different stiffnesses of gel plates. So mimicking the different stiffnesses of placenta in hypertensive disorders of pregnancy. And what we were able to show is that in cells growing on the stiffest gel plates, those that were at that 55 kilopascals, as opposed to the 8, we saw increased mitochondrial stress in those cells that were growing in a stiffer environment as well. So all of these experiments are setting up a lab environment that is meant to mimic the intrauterine placental environment. And then we said, okay, now we've kind of created these environments that show what cells are like in the lab and in utero, and they're acting the same. what if we give them some of these resolvents, and we have a lot of knowledge about the potential benefit of the resolvent D2 that Dr. Hanson talked about on that first slide. And the resolvent D2, increasing that in these series of experiments actually can decrease the expression of that tumor necrosis factor alpha. So all of these sets of experiments are just building on the evidence that if we can modify the diet at critical time points, we can decrease inflammation and hopefully get a healthier environment for the placenta, the fetus, and the mom based on a simple dietary intake. So I'm going to pop it back over to Dr. Hanson, and she can talk about some of our work in understanding how the diets of pregnant women are here in the United States.
Yes. So I see that we're running a little short on time. I do want to leave time for any questions. So I think I can summarize this slide for you very quickly. I think hopefully some of our research has made it clear that omega-3 fatty acids are important during pregnancy and could be very, very key in the management of the disease that we're talking about. And we do really terrible. The data that we're presenting here is national data. So you can see the red bar is where you should be, and the women, pregnant women are the blue bar, and women of reproductive age are the yellow bar, and none of them are getting even close to the red bar. So intake of omega-3s is very low in pregnant women. And it's hard. It's really hard. I think, one thing to understand is how hard it is to get the best sources of specifically the molecules that we were talking about, the DHA and EPA that are the precursors of these compounds that we want. The best source of them is fish. And there are two things working against us there, I think. And one is that the CDC has the guidelines that say pregnant women should limit their intake of fish because of the risk of mercury contamination. And then the second thing is that there's a lot of pregnant women that probably fish just really doesn't sound very good to. Like with Lashelle, maybe pineapple, but pineapple is not a good source of omega-3, so no help from the pineapple. And another thing that shows up in our research is the same thing that Anne and Lashelle were talking about early on, is that the populations that are sometimes at highest risk for stress and pre-eclampsia and adverse things happening to mom and baby are the same populations that are at highest risk for health disparities related to diet. Our work also shows pretty clearly that the lowest of the low intakes takes place in women who have the lowest socioeconomic status, the lowest education levels. They're definitely women of color and things like that. So there are significant barriers to improving access to this possibly helpful intervention.
All right.
Yeah,
So
wrap up there. Yeah.
yeah, it has just been a pleasure to have all of you here today. And I love seeing the chat questions and having some conversation through the session. I think we have a few minutes. We could answer any other questions or have any discussion that might come up.
Let's see. I do have a question.
Oh.
So I finally got to see some of the pictures from the surgery. So Arnold I guess he was allowed to take pictures, and he got pictures of a knot in the umbilical cord. Is that something that also caused by the hypertension? Is that like a thing, or do you know why there was a knot in my umbilical cord? Or sorry,
it's just an extra complication. You just got it all from not related to your hypertension. Your hemorrhage was most likely related to your hypertension. Those go and
yeah.
But the knot is just another piece of bad luck.
Oh no! And so it was like really huge. So I actually got to see the picture. So sorry, just wanted to ask that.
Good question.
I've been wondering what was going on. So thank you.
Maybe it means your baby's going to be a sailor or a rock climber when he grows up. He was just practicing knot tying from a very early age.
Oh my goodness. He wants to go. And I'm like, where are you going? I'm like, you can't do this yet.
I'm going to
Thank
read this
you.
for the recording because I know other people are planning to watch this remotely. And this says, for African American mothers that have experienced high-risk pregnancy like preeclampsia and C-sections, we have funds for extended postpartum care. Please refer to OmahaBlackDoulaAssociation.org or text 402-320-0638. And the Omaha Black Doula Association is an amazing resource, as is IB Black Girl. And we work very closely with both of those organizations to try to get resources to the moms that need it most. So thank you for putting that in the chat. That's just critical information for everybody to know about.
That's terrific. And with the recording of this video, I can put that information within the notes of like the YouTube video once this is posted. Any
Excellent.
additional questions about how to guide mothers and some of their nutritional habits? Looks like you did a pretty good job, ladies. I don't see any other questions.
Or we put you all to sleep with the biochemistry at the end. Sorry about that.
Lots of good stuff, but we need omega-3s in the diet, right? That's the
They
key.
are a healthy choice, you know, and I think I don't want everybody to walk away and only eat fish, salmon, nuts, and eggs, everything in moderation. But really, the Midwestern diet has such low intake of omega-3s that any improvement that you can get in that will have life course impact in your health. So it's a good thing to focus on and try to ease into your diet if possible. And more to come from our lab. Hopefully we'll continue to work through some of these breakthroughs and continue to advance care.
Terrific. Well, thank you to all the panelists, especially Lashelle, for just being so awesome and sharing her story. Somebody did ask a question real quick in the chat about supplements. I think we have a few minutes that we could address that real quick.
I was waiting for that question. Here's the loaded question. Yes and no. The supplements are a really, really hard topic to address in nutrition. You would think that this would be pretty easy. You would think you'd say, oh, we don't get enough omega-3s, we should just take a supplement. And it's really going to be that simple. Most studies of supplements have very mixed findings as to whether or not they work. And most supplements, specifically supplements outside of omega-3s, if you start looking at some of the other fat-soluble vitamins and things like that, taking supplements of them is actually associated with bad things happening. And we think the reason for that is that once you pull a compound out of food, you take away all of the other compounds that it interacts with. There's lots of fatty acids besides DHA and EPA, and a lot of them probably work synergistically in ways that we don't even understand. If you are going to decide to take supplements, and some of them just don't work because it's actually hard to get supplements in a form where they can be incorporated into the red blood cell membrane. That's what needs to happen to omega-3s in a way that's cheap. It's really expensive to maintain the properties of the fatty acid so that it can be incorporated into red blood cells. If you do decide to do it, you need to look for a supplement that is non-esterified. It should say on the label, no esterification. There's an oil on the market that is a really nice source of omega-3s, but it's $45 a bottle, and a bottle really doesn't last that long. And so that's the kind of thing that we're talking about. So we do encourage people to try and see what changes they can make in their diet first. And as a last resort, if there's just no access to it, or it's food that you just really don't like, then we would, I think, cautiously go down a path of possible supplements. I just am giving you the wishiest, washiest answer ever, but I think the bottom line is that they are maybe also not without risk. But our population is low enough in omega-3s that I think, yes, Ann and I do consider it. And we are proposing research to really try and test that, to see if we can give pregnant women supplements that would actually increase production of SPMs. Because if you can't do what you're supposed to do with them at the end of the day, it doesn't matter. If a pregnant woman takes supplements and it can't be converted to SPMs, then it doesn't matter. It was kind of for naught. So I guess stay tuned.
Yeah, that is incredibly useful information
It's
because
actually it's not helpful at all.
take a pill. It's so easy to say,
Because
take this
it's such a
pill,
non-answer.
and it'll make you better, or it'll cover it. And
Yeah.
I think some people have that association. So that's
Absolutely. Yeah.
that's
I
really important.
think I see your, yeah, okay. Yeah, some brands or places to get affordable supplements. Non-esterified, any brand. There used to be a Walmart brand on the market that was actually not a bad brand. I can't speak to whether or not that's still current, but if they list on there that it's non-esterified and it's usually going to be from something like krill oil or something like that, then you could certainly consider it. No idea what the price is on that currently, but that was one of the most reasonable options. And there was actually a little bit of research behind it. Anne and I have collaborated with a person that actually studied it in different disease states to make sure that it increased serum fatty acid levels. Again, the SPM production end of that really is not very well understood.
Great. Well, thank you all. I know we've hit the top of the hour and some folks are falling off. So thank you for attending. I did list or put in the chat a survey about this presentation that will just help us with planning future events. So it'd be helpful if you would go ahead and click on that, and I will send out a follow-up email with this recording and with that survey attached to it. Thank you all and have a very good day.